Thank you, Madam. I'd like to thank
So Dr.
AIOC,
Fairooj has joined us.
yeah, AIOA Scientific Committee and Dr. Kusandana Chakraborty Madam for this kind invitation. So I'll be talking on nuances of MRI and CT scan in orbital inflammation. Sripurna has already described that orbital inflammatory disease include a spectrum of conditions affecting the soft tissues of the orbit, including idiopathic orbital inflammatory syndrome, thyroid eye disease, and infectious orbital cellulitis. The importance of proper diagnosis and the timely diagnosis is, this thing is actually, it's a potential visual threatening and may require a prompt diagnosis so that we can do proper treatment. And there must be a differentiation from the neoplastic or infectious process. These are the gross classification of orbital inflammation. We can divide it into infectious and non-infectious. Among the non-infectious, there are many types like systemic inflammatory disease, neoplastic, vascular, and idiopathic. And the diagnosis of orbital inflammation, these cases are mainly based on history, clinical examination, imaging of the orbit, and laboratory investigation. The imaging plays a crucial role in diagnosis, differences from the neoplastic condition. It determines the extent and severity of the lesion and guide us for the therapeutic approach, whether we have to go through medical treatment or we have to urgently go for any surgical treatment. The main investigation which is usually in practice, these are CT scan, MRI orbit, and USG B scan. However, USG B scan is very much technician dependent and operation dependent, and it's not always used in case of only it is used for some cases of suspected cysticercus or orbital abscesses, but it is not routinely done, so I will skip this. First, we have to know the planes of orbital imaging. We have axial imaging, where the scan has been done through the horizontal plane, which is also known as Frankfurt plane, which lies which is from the orbital floor to the external auditory meatus. Next comes the coronal cut, which is the vertical plane, which takes the picture of the orbit from front to back. And last is sagittal section. It is also a vertical, cutting the tissues in a vertical plane, but from side to side. First come to CT scanner orbit. It has a crucial role for rapid diagnosis. It is important. The advantage of CT scan is it is rapid imaging, because in some cases like orbital cellulitis or orbital abscess, we have to diagnose the case promptly. So this CT scan is very much useful in these cases. It also gives superior bony details, like in this case with a tumor with a bone erosion or fracture or hyperostosis, like fibrous dysplasia, etc. It also gives some good tissue contrast, like in case of thyroid eye disease, you can see the muscle bulk, belly, and also some fat strangling in active disease. First, we'll go by the cases. In the key picture of CT scan, we see in orbital cellulitis is soft tissue edema. Both in orbital cellulitis, both the preseptal area and the postseptal area is enhanced. And the second point is loss of orbital spaces delineation. You cannot clearly delineate the demarcation of intraconal space, extraconal space, nerve, etc. Next point is strangling of intraconal fat. In normal normal orbit, you can see this black area. This is a normal intraconal fat. However, in orbital inflammation, especially orbital infections, there is some reticular pattern of enhancement. This is known as strangling of intraconal fat, and it is very much characteristic of orbital infection, cellulitis. Next is extracellular muscle edema. In severe infection, there may be the muscle belly is there is some thickening of the muscle belly because of fluid collection. One most important part of CT scan in orbital cellulitis is it detects the paranasal sinus mucus thickening and fluid collection, which are very common in orbital cellulitis, which needs surgical treatment. And subperiosteal and orbital abscess, there is collection of fluid under the under the suborbita, and in this case, these cases actually need urgent surgical intervention. Next is non-specific orbital inflammatory disease. Non-specific orbital inflammatory disease, already Dr. Sripurna has told that it may affect only the lacrimal gland, that is known as dacryoadenitis. In a classic lacrimal gland enlargement can be seen in CT scan. These are the enlargement of the lacrimal gland here in both the side. However, this may happen also in other diseases like some tumors like lymphoma and other diseases. For that actual diagnosis, we have to go for MRI with some special protocol like DW1. Next is enlargement of the extraocular muscle belly with a tendon. This is myositis. Here you can see that both the muscle belly and the insertion is inflamed, enhanced. See, in thyroid orbitopathy, we can see the thickening of the muscle belly, but which spares the tendon. The muscle belly thickening, the order is the most common is inferior rectus, medial rectus, superior rectus, lastly lateral rectus. Where is in another orbital disease, which is immunoglobulin GG4 disease, we see the lateral rectus is the most common muscle to be involved. This also can be detected in CT scan orbit. And in very severe activity score, we may also find, along with the muscle belly thickening, lacrimal gland edema. Next comes to the orbital MRI. It is the modality of choice in evaluation of orbital inflammation because it gives us superior soft tissue resolution which differentiate the inflammation from the neoplastic disease. It gives a better optic nerve and intracranial assessment useful in chronic cases and autoimmune diseases. But first, we have to know the protocol. This is the T1 weighted image, which is basically used for anatomical detail and structural assessment. Here, inflammation appears to be ISO or hypo-intense. This is than the normal orbital fat. This is the orbital fat, and this is ISO or either same or hypo-intense, that is less brighter. In T280 scale, this actually highlights the edema, fluid accumulation, and it is often seen as a hyper-intense lesion. In active inflammation, the structure shows it's very hyper-intense, that is very much brighter. And when there is chronic inflammation, fibrosis, it may appear as a hypo-intense because of less water content of the tissue. Next is post-contrast T1 weighted imaging. When there is a fat saturation, this enhancing lesion or inflamed tissue appear bright due to increased vascularity. So the pattern of enhancement differentiate between the inflammation and tumor. When there is inflammation, it is more homogeneous. When there is tumor or infection, it is usually shows heterogeneous. And then next comes diffusion weighted imaging. It's a special imaging pattern which shows the diffusion of the gadolinium contrast in the tissue. Here, inflammatory lesion will have less diffusion restriction, and because of the high vascularity, and will show high ADC value. But in malignant tumor like this, there is higher cellular content which will restrict the diffusion. You can see this is the diffusion weighted picture. In the first picture, this is orbital inflammatory disease. This show high ADC value, whereas the malignant tumor, this is showing the less ADC value and low diffusion restriction. The first case is a 21-year-old lady who presented with swelling and on and off on 6 months. There is no systemic illness. She has no thyroid illness. There is mild proptosis. On examination, she has mild limited abduction, and there is a pain on ocular movement. On CT scan, we can see there is thickening of the medial rectus and lateral rectus belly with the tendon and post-contrast lacrimal gland enhancement. This is the post-contrast picture. Lacrimal gland is enhanced. So I did an incision biopsy, which came out to be a non-specific orbital inflammation. Patient treated with oral steroid, and now she is doing well. This is the second case. It's a 35-year-old lady. Both came with a upper lid swelling, both eye for last 1 year. She also has some dry mouth, foreign body sensation. Sorry. On ocular examination, the vision was normal. but there was both eye upper lid. There is diffuse swelling and, sorry, I'm just finishing. Mild erythema. This is the 9-gauge picture which shows restriction. So we differential diagnosis was Sjogren sarcoid, IgG4, lymphoma, etc. So after investigation, all are normal except immunoglobulin GG4 level was raised. So on imaging with contrast, we see there is T2, there is hyper intense lacrimal gland, and one interesting thing is enlarged intraorbital nerve, infraorbital nerve. So my first clinical DD was IgG4 disease, did an incision biopsy, but there is a surprise. It showed a lacrimal gland infiltration with medium-sized lymphoid cell, and this patient underwent chemotherapy and now she is doing well. This is another case which presented with acute proptosis with dimness of vision. These are the disc picture you can see in the right eye, and in the CT scan you can see diffuse enhancement of the intracorneal space, which is quite finely molding the globe. So I thought it could be a lymphoma, but it ultimately came out to be a IgG4 disease. This is the 6-month picture. The next case is a 30-year-old lady who presented with sudden pain and ptosis of left eye. And she has having inability to move eye in all gauges. In CT scan, you can see there is thickening and enhancement of the left cavernous sinus. This is the left cavernous sinus, which is extending also to the apical region. So the provisional diagnosis we made, this could be a case of orbital apex syndrome. This is the blood investigation is normal, except ESR was high, ANA was positive. So this is a case of Tolosa-Hunt syndrome. She responded very well with 3 doses of IV methylprednisolone for 3 days. So when to use which one, there is just a gross guideline. In orbital cellulitis, the first investigation should be a CT scan because it gives a quick and detects abscess and sinus involvement. In suspected idiopathic orbital inflammation, MRI is a better choice because it will give us a better soft tissue contrast, rule out, it also helps in rule out tumor. In thyroid eye disease, both CT and MRI is useful. CT give the extraocular muscle changes, and MRI is better for optic nerve compression sign. In orbital tumor inflammation, MRI with diffusion weighted imaging is very important, which differentiated inflammatory from the neoplastic lesion. And in Tolosa-Hunt syndrome, I just see it's MRI is the investigation of choice to assess the cavernous sinus involvement. So the take-home pearls is CT and MRI has distinct advantage, and their selection depending on the clinical suspicion and the need for soft tissue versus bony evaluation. CT scan is the first line imaging in acute orbital infection and trauma. However, MRI is preferred for orbital chronic inflammation, optic nerve involvement, and intracranial extension. Ideally, CT scan and MRI both complement each other in some cases, like some complex cases. Thank you.
Thank you, Dr. Joyeeta.
I'd like to invite everybody. Just a minute, show the last slide, please. This year, we are organizing OPAI annual function from September 19 to 21st in Kolkata, and I invite you all to join us. Thank you.
Thank you, Dr. Joyeeta. I have a question to you.
Yes, ma'am.
If in a case of TED, patient has come because all of you, both of them are coming from a government sector. Many times either CT is there, MRI is not there, like this. Which one you will suggest for? You said both CT and MRI to be done in TED.
But in CT scan is quite useful in these cases for early diagnosis because all patients cannot afford MRI still in our group of patients. So CT scan can show the muscle pattern is very nicely. So you can have, but when we're suspecting some apical compression is there, then we can do a
So in a case of thyroid eye disease, we can go for the
CT scan first. Yes.
We will go for MRI if you see that there is a compression at the optic nerve head. Then only we will go for apex of the orbit. Then
to look for apex
to find out the muscle belly thickness. And Anirban is saying something. Anirban. Yes, please. Please, a microphone, the hand mic.
Since we have ultrasonography there, we usually go for ultrasonography whether tendon is involved or not, or the muscle belly is involved. Then only we follow.
Yes, that's a good approach. Yeah, you don't have CT scan there. USG is a good approach. You can very handy in the OPD only. You can do it yourself. Only thing is that you have to measure the thickness of the muscle very carefully, and for that you need experience, and you have to learn it thoroughly. Otherwise, it is difficult. What is the thickness and all measurement? But if you do it routinely, then you can become expert in that. Dr. Anirban is something.
About this use of
CT.
MRI versus CT in thyroid eye disease. So, like you pointed out, so CT scan is something that you can do quickly. You will get results very fast. You don't need to book time because MRI is a long procedure. That's why fewer patients are done on the same day. So when you have a situation like thyroid optic neuropathy, a CT scan actually serves the purpose better because all you want to see is crowding in the back of the orbit. You really don't want to see the inflammation of the muscles, right? So that is something when you have a situation where you want to decide, do I want to treat or not treat the patient with systemic steroids, there MRI is more useful. But when you have vision loss in a patient with thyroid disease, CT scan serves your purpose because you are able to prove the crowding in the apex even on a CT scan.
Yeah, exactly. Thank you, sir.
Okay.
So thank you, Dr. Joyeeta, for the
Thank you.
excellent